sure that I'm really in it. Victoria's in there.
How do you pronounce her last name? You know?
Eidson.
Eidson.
I think it's Eidson.
Yeah, it's asked her this
Eidson?
morning. It's no, like I would have never known that.
Eidson?
I was like,
That's
yeah,
wrong.
Eidson. That's what I said.
Is anybody talking? Hope not.
Hi, Eric, can you hear us?
Oh, there we go. Hey, I was like, uh-oh. If someone's talking, I can't hear them. Is there just one video going? Are you the only one on?
Hey, I saw you got the memo, huh?
Which memo?
The pink shirt.
Oh, no.
Looking sharp, man.
Yeah. Why do I not have a gallery view? I only see you.
You should see the panelists. So you should see just you and then.
Where's Victoria?
Yeah,
She-
Victoria's
she
on
gotta-
here.
Actually, Angela
Victoria.
is called in as a participant and she can hear us.
Okay.
Okay.
So the
There's
attendees
Victoria.
are listening as well.
So we need Nick and Neil.
Yeah, I'm on.
Oh, okay.
Where's
So
I
you
know.
were on by, okay,
you must be the, are you the, do you have a camera?
No.
but you are on your computer, right?
Yes, I am.
Okay, it's not showing you as a panelist, so let's just find you. Can you talk again so I can see your screen light up?
Yep, right here.
Okay.
That's him.
For some reason, it's saying everyone is Victoria, so I changed Dr. Manahan's name, and now we will change yours so we know who you are.
So we need Neil.
And we'll just do just a minute longer. We're letting a few more come on. We've got,
I'll text Neil.
I just spoke with him, so
Oh, so he
he
knows.
does know, yeah, but
Okay.
he, let's see. Make sure I get his name spelled right.
Should we say hello to our participants since they're listening to our pre-game warm-up? Since it's 11:32. I'm not sure what time our start time is.
Yeah.
Hi, participants.
There we go.
There's Nick.
Looks like we might be getting Dr. Patel on here.
That's
I wonder
okay.
why I'm saying that. That's pretty strange.
We're almost ready to start. I think we're close.
Just gonna do one thing real quick. Yeah, you can have-
Hi, Neil.
Hey.
Neil, can you hear us?
Yeah, can you hear me?
Yes, we can hear you. We're almost ready to get started. We're just letting a few more of the attendees come in. I think all the panelists are here.
This is gonna be. That's gonna be top one more. We need to rename them. I want to make sure that
Yeah.
which one is.
Hi, hey Neil, can you say something? We're going to rename you.
Can you hear me? I'm here. Check, check, check.
Yeah, we got you. Thank you.
Victoria has hers. Victoria has hers.
I think Victoria's right under here, so it must be.
Well, hers
Must be
was
this one.
oh, because he had his in there. Yeah, that's right. Strange. Wasn't it just a minute?
At least the panelists or the attendees are lucky in that they're only seeing Neil Patel and Dr. Nick's words of their name instead of their faces.
I can fix that.
Oh
You may,
well.
you may not want that, but I can fix it.
We need to see your face, Dr. Patel.
All right, let me see. Hold on.
Fire that thing up.
And your face, by the way, your all audio is being projected to all the attendees.
Can you see me now?
I do not.
Not yet.
Well, you look a lot better than you normally do. I can just say that.
That's my stand-in.
Is it?
I'd go with that all the time.
I could change it back to.
It's very odd how it's got Victoria in it.
No, I've never seen that.
So, should we go ahead and get started, you think?
Let's do it. We've got 30 on there. They didn't say that. Opening slide.
Go ahead.
Yeah, it's gonna be.
Well, I think let's go ahead and get started so we can get through the program. First of all, I just want to introduce myself. I'm Dr. Eric Turner. I'm the medical director here of Oncology at the People's Cancer Institute. And I just wanted to welcome all the attendees to the breast health webinar today. We're excited to be able to present some information to you. Our goal here, as you can see, is to try to have an in-depth discussion of breast cancer risk, some of the latest guidelines, as well as some of the treatments, especially as it pertains to radiation, as well as some nutritional information and prevention techniques. Again, I'm Dr. Eric Turner. I'm a medical oncologist here at PCI. Our presenters today will have Dr. Eric Manahan, who's our board certified surgeon and breast health surgical specialist. Nick Gallinopoulos, who is one of our 2 radiation oncologists, will be with us. And Neil Patel, who is our board certified radiologist, presenting today. And we also will have Victoria Eidson, who is our registered cancer center dietitian. Just a few housekeeping items. If you will please use your Q&A feature at the bottom of your Zoom window if you have any questions. Some of those we'll answer privately during the webinar. Some will be answered live, and then there may be some that we'd also answer privately after the webinar via phone or email, but we'll try to get to as many questions as we can. There's going to be an interactive poll near the end of the webinar during the nutrition section. So if you will please participate in that, we would greatly appreciate it. And that is anonymous. So again, feel free to participate in that. That'll be helpful to see if we have kind of learned anything during our webinar. And then also note there's going to be a couple $100 Visa gift cards to give away at the end. Now you have to be attending to win those. No, Manahan, you are not eligible. Participants are not eligible. So we're going to show those. All right, there we go. And we will contact you to arrange for your pickup or delivery of those after we're finished. So again, I'm Eric Turner. I'm going to talk a little bit about women's services here at the PCI. We're really excited about what's going on with breast cancer here. It's been really a focus of ours for quite some time, especially since my arrival in February. We've really been working hard on our breast cancer program. We have a comprehensive team of medical oncologists, which would include myself, Dr. Duhaime, and Dr. Jung. We have 2 radiation oncologists. We have a team of radiologists that help us here. And then we have a team of surgeons specializing in breast surgery. As Dr. Gallinopoulos will discuss, I'm sure briefly in his presentation, PCI is equipped with state-of-the-art radiation equipment, and our radiation therapies are state-of-the-art here. We customize treatment plans for your breast cancer. It really all goes into the type of breast cancer you have, the staging, the imaging, and what your therapy will be from a surgical, radiation, and medical oncology standpoint is all customized. Genetic testing and counseling available. Dr. Manahan will go over that in detail. Imaging wise, our imaging center is located here in the PCI. We have 3D digital mammography. We have 3D stereotactic breast biopsy capabilities, ultrasound, elastography. We have a patient navigator that helps navigate you through the whole process from the time of an abnormal mammogram through the biopsy, through any treatment that you may have to have. We also have oncology social work services here at PCI, which has been very, very helpful in trying to move therapies along and help with financial things and just other social situations that come up during your cancer journey. In addition to our breast surgery, Dr. Manahan and his colleagues also work very, very closely with our plastics folks, our plastic surgeons, to help with reconstruction, sometimes which is often immediate or delayed, but we have that capability as well. Just briefly wanted to kind of show you our other team members who are not with us today as panelists. Again, we have Dr. Duhaime, who is a medical oncologist, hematologist, who's been with us here at PCI since 2018. We also have Dr. Chen Jung, who is our hemonc colleague as well, available to see patients. Our second radiation oncologist is Dr. Arif Ali, who works with Dr. Gallinopoulos downstairs in the radiation center. And then we also have an advanced nurse practitioner, Frida Hoffman, who is sort of does everything at the PCI. To be honest, she is an oncology certified nurse, nurse practitioner in hemonc. So we're thankful to have Frida. We're going to show a brief video, if we can get this to come up, hopefully, of our open house.
You know, God has blessed us.
We've been blessed with Whitfield County. Been good to us.
So we're giving back.
I've seen multiple cancer centers across our country. This cancer center is top notch. I'm excited to be chosen as the person to lead it. Our goal here is to provide excellent, world-class cancer care.
This facility is an amazing economic development project for Dalton and Whitfield County. It essentially transforms Hamilton Medical Center into a regional healthcare system, which is amazing for our community.
Notice when you walk in the first floor of the building, that's where all the cool tones are. And as you move through the building, it gets warmer. In the art, we tried to reflect that and bring the warmth as you move throughout the building.
We exist really to meet the healthcare needs of the people that we serve. This is friends, families, and neighbors in all directions. And so the Cancer Institute is kind of the next step on that journey. This facility enables us to recruit the talent, the skills of the people that can really provide the best care possible. And we think we've done that. And so we're very excited about it.
So hopefully that was a sort of a brief look into the facility itself. Certainly we're excited about the PCI and the building structure, and I know my colleagues on here will also back me on this, but we're very thankful for the People's Family for all of the support that they put into making this center happen. So they're wonderful people. I've had multiple opportunities to meet with them, and we really are thankful for their support. Last thing I'm going to really say in my portion here is kind of a coming soon. Some of the things that we're working on, mobile mammography, while we have those capabilities here, we as a team have sat down and kind of decided that to have the ability to purchase a mobile mammography van and take it out to patients, whether it be in remote locations or to, say, factories where it would make having a mammogram much easier logistically for patients, is something that we wanted to pursue, and that is in the works and hopefully coming very, very soon. We also are having a new MRI unit with a breast coil, which will increase our ability to advanced image the breast, whether it be for high-risk disease or for surgical planning. So we're very excited about that, that feature that will be coming here in the next couple months. And then I also want to take this time just to introduce a new member of our team, which is Dr. Courtney Perez. She's a fellowship-trained breast mammographer and expert in MRI reading. So Courtney will be starting at the beginning of next year. And we're excited about having Courtney here, and are lucky to have her. And I've known her for about 15 years, and she is an excellent breast radiologist. And so we're excited about having Courtney. And so with that said, I wanted to introduce Dr. Eric Manahan. He's going to talk to you about breast cancer genetic testing. Also, hats off to Dr. Manahan. He's worked very, very hard about with regard to getting a Paxman scalp cooling system, which is a hair loss prevention technique or apparatus that we have available to us here at the PCI for patients to use. And Dr. Manahan's going to talk about that. And with that said, Dr. Manahan, if you can share your screen, we'll go through your slideshow.
All right. Thanks to be here. Thanks for the invitation. Let me see if I can get this going into presenter view. Come on, presenter. Okay. Are we good? I can't see anybody now because I can just see my slides. So
You're good.
I think you're good.
all right. So Eric Manahan again. The other thing is we can monitor that chat function if there's any questions. Happy to answer those as well. So glad everybody's here. Two really exciting things that I really enjoy talking about are genetic testing, and then like Dr. Turner had said with the Paxman scalp cooling system, it's really a great addition to our multiple things here at the Cancer Center. So I'm going to just pop through a couple slides, probably won't go through them all together, and just read them to you. But one of the big things that came out a couple of years ago that we helped lead at the American Society of Breast Surgeons is the genetic testing. And so women that are diagnosed with breast cancer, we believe all should have a discussion with either their oncologist or the surgeons, but feel that everyone should at least have a discussion about genetic testing. We do a terrible job in the medical community overall of figuring out who needs to have genetic testing. And so one of the things is that eventually in 10 years from now, probably everybody will have it when they're born and we can just go through it at that point. But now it's trying to figure out who exactly should have it. And one of the cohorts of people that should have it are women or men, obviously diagnosed with breast or even ovarian cancers. We continue to raise the number of people and the number of indications to have that done so that we can find women that should have that, women and men should have the genetic testing as well. So as all of you know in statistics, breast cancer is the most common cancer in the United States. 268,000 women diagnosed with invasive cancer every year. So 3.8 million women are living with the diagnosis of breast cancer. So tremendous number of women across the United States that have this diagnosis and are living with it every day and are reminded about it every day. Ovarian cancer, again, also very significant and again needs to be concerned, especially with genetic testing and any family history of ovarian cancer. So the main genes that everyone's heard about are the big ones, the BRCA1 and 2, which essentially got renamed by Angelina Jolie when she came out that she had these genetic abnormality and really helped to put this in the forefront of people's minds as far as genetics. So those are the two biggies, but now we've got a multitude of even more genes that show almost as much of a concern for genetic testing as well. So they were discovered in 1994, 95, and this is the biggie. There's about 1 in 300 to 1 in 500 women across America that have this gene that we just don't know about it. So it's still only 0.2 to 0.3% of the population. Most of the time, people really don't have it in a population. You'd be more likely not to have it, but in women, especially younger women, 6% of those less than 40 can be diagnosed, that are diagnosed with cancer, actually have the gene. And in the Ashkenazi Jewish women, there's a significant increased risk for those women as well. But overall, in the number of breast cancer patients, the true genetic abnormalities come down to about 10%. And of those, BRCA1 and 2 mutations have a increased risk or have the most prevalence in those women. So we like to test everyone now with breast cancer to find out if they have that gene, and then also some of the others so we can change some of the treatments. And then the thing that allows mostly as well is if someone is to have one of these genes, there's a 50-50 chance that was passed on to one of their family members. So then we want to spread out from there and do what testing of family members to find out if there's people that we can help to prevent cancer in, because that's the ultimate goal, is to get to these people before cancer develops. Again, some history that really is not that important, other than we're getting better and testing more people and we got lots more genes to test. But again, we've only identified really less than 10% of the people that have these genes out there. So there's millions of women walking around that haven't had this testing. There's a very even number of patients that have had cancer that's never discussed genetic testing with one of their healthcare team members. So even if you've had this diagnosis 15, 20 years ago, it's important to bring that back up. And we try to do that back in the office, either in one of the oncologist office or in our office. And there's a significant number of genetic counselors out there, but really they're very limited in their scope. So it's trying to get those people tested. So we know that we are under testing people, and we know that we should test everyone that's been diagnosed. So that's essentially the spiel on genetic testing. We can talk all day long on that, but I just wanted to kind of give you a brief overview, and the take home is, if you've been diagnosed with breast or ovarian cancer, let's have a conversation to get you done. And we're going to begin screening everyone that comes through PCI to get a screening mammography. We're going to help try and determine, are they at high risk? Do you need an MRI? Do you need genetic testing? So when you have your screening done at PCI, that will also be a part of the new going forward to figure out how we can do a better job of finding out individuals that may be at high risk or have a genetic abnormality that we can treat before you get to the cancer part. So complete driving down the road and slamming your car in reverse and jumping to the Paxman scalp cooling system. So this is mostly at big academic centers they use this, but because Hamilton is so really dedicated towards treating our patients and trying to get state-of-the-art technology, we've been able to pull this in. And what this is, as everyone knows, chemotherapy can be very devastating. After you get the diagnosis of cancer, do you need to have chemotherapy? And if you do need chemotherapy, the first question I always get is, am I going to lose my hair? And yes, chemotherapy, because it likes to get a hold of cells that are rapidly dividing, that unfortunately translates into hair. And so most people, or a lot of women and men that are undergoing chemotherapy, will end up losing their hair. And that's very emotional to patients. And we want to do everything we can to try and help with that. So we have this Paxman scalp cooling system, which essentially you wear like a little swim cap over your head, and it pumps. This device will actually pump some coolant system into this little scalp cap. And what that will do is cool the scalp down while they're receiving chemotherapy and help to try and at least slow down, or even at sometimes completely prevent hair loss. But it will definitely slow it down. And even if it doesn't completely prevent hair loss, it does. New studies are showing that it'll help to make these follicles come back and start creating hair quicker in those that even where we've not been as successful in preventing the hair loss. Unfortunately, it's considered cosmetic, and so it's not necessarily covered by most insurances. So then because of that, we're trying to, again, because of Hamilton, the Healthcare Foundation is really going out of their way with businesses to try and help raise money to give this to every patient that can be a candidate for that without having to worry about the cost. It can be expensive, but we want to help mitigate that cost through the foundation in order to bring this to you and your family, because it's an emotional part, and we want to do everything we can. Again, state-of-the-art care in this cancer center from top to bottom, excellent colleagues, excellent oncologists, radiologists, rad oncs. We got everything that you could have at a big place here in a small town where we can treat you close to home. I'm going to play a quick video that the foundation met, and then I will sign off. But this is, again, just another, I hope we can hear the video. Can you hear the video?
First chemo treatment, and
okay.
I don't know, maybe a week or so later, I put my hand up to my head and pulled, and I had a lot of hair in my hand. Within the next week, my hair eventually, pretty much all of it came out, and I got my husband to shave my head for me. And it was at that time I looked in the mirror and I said, I'm really sick. So when my friend told me about this machine that's being offered to patients, being able to look in the mirror and look like themselves and not look like they're sick is awesome. It really is.
When you're dealing with cancer, there's a lot of internal strife. There's a lot of anxiety, and you're feeling that on the inside. Hair loss is a visualization of that anxiety. So the hope with a Paxman system and a cooling cap is that if you can diminish the hair loss or even prevent the hair loss, it gives a real big morale booster and ultimately allows patients to fight through and get through the end of their therapy. I think that's really the big bonus.
And a lot of people say, you know, they have no problem with chemo and it doesn't make them sick. Well, I'm not one of those people. I do get sick. I have good days, I have bad days, but I don't want to look in the mirror and see no hair, because even on your best day, you know, you get up, you put your makeup on and you're having a great day. You look in the mirror and when you see no hair, it just reminds you that you're sick. So I think if anybody can keep that, then it's worth a shot.
It almost gives you chills just to know that, you know, you're giving this patient hope. And I know for a lot of people, you know, hair might not be a lot, but for these patients, it's a big thing. And to be able to give them hope that, you know, you might be able to have control of something, that's amazing.
Unfortunately, the Paxman cooling system is not covered by insurance because it's considered cosmetic. So that's why we need your help to really help fund this. Our mission at Hamilton is to take care of patients no matter their ability to pay. And we want to provide this to every patient and give them the opportunity to use this whether they can pay or not.
We at Dalton Utilities are excited to be part of this partnership. We've seen our employees and some of our employees' spouses and even children walk this diagnosis of cancer. And it's just heartbreaking to see all the things they have to deal with. And the hair loss and eliminating that can be so beneficial. And we just want to be part of this challenge.
I've always said there is no community more loving, more giving, more supportive than Dalton and the surrounding Northwest Georgia region. Our Hamilton Business Alliance Committee has committed to raising funds from our community, and I challenge all of us, individuals, families, businesses, to come together to provide these services for our patients. There's a wish list here at People's Cancer Institute, and this is the beginning, and we want to bring the absolute best in care to Dalton and Northwest Georgia.
Peoples plus Paxman plus you.
Peoples plus Paxman plus you.
Peoples plus Paxman plus you.
So thank y'all again for trusting us with your care, and we're going to turn it over to the next speaker. I guess Dr. Turner will introduce them.
Yeah, Dr. Manahan, I did real quickly before we move on to Dr. Gallinopoulos. We had a question, and I apologize to the attendees. We're not seeing the name. It's a technical hiccup we're having, but one of the attendees, Dr. Manahan, asked if genetic testing is covered by insurance, and if not, how much roughly is the out-of-pocket?
So great question. It's kind of a trick question. A lot of it is covered by insurance, depending upon the indication. But there's also, it used to be thousands of dollars, but now you can, even if you have no insurance, you can get a multi-gene panel testing through some of the companies for really about $300. So it's, the cost has come significantly down. Most insurances will do some coverage, but you can do an out-of-the-pocket, no insurance test for around $300 now.
Okay. All right. Thanks for that. Again, Dr. Manahan, thanks so much for that presentation. Just to kind of follow up on that Paxman system, we do have several patients using it and are having good results with the units. And so we're very excited about that, about our capability of offering that to patients. And it's been awesome. And again, I appreciate all the hard work you put in, even before I got here, to get that system up and running here at PCI. So with that said, we'll move on to our next presenter, Dr. Gallinopoulos, radiation oncology. Nick, are you with us? You can share.
Yes, I am.
Okay.
Let's see here. Can you guys see my slides okay?
Yep, I think so.
Okay, very good. So yeah, so I'm Nick Gallinopoulos. I'm one of the radiation oncologists here, along with Dr. Ali, who's one of my partners here at Hamilton. Today, I'm going to give a little talk about a little bit of an introduction to radiation, because a lot of people don't really know what we do, and so a little info about that, and then I'll sort of segue into a discussion of some of the unique capabilities we have here at Hamilton at the People's Cancer Institute with regard to avoiding radiation dose to the heart, and so I'll go through some of that with you guys today. Don't have any conflict of interests. So what is radiation oncology? A lot of people, when they come in and get referred to us, they have no idea what we do and are kind of scared. The word radiation can be kind of scary. And, you know, a lot of medical fields, they have their sort of stereotypes, and, you know, people kind of know what orthopedic surgeons do and anesthesiologists and pediatrics. And when it comes to us, you know, a lot of times no one has any idea. So I thought it'd be good to give you guys a little bit of an introduction to what we do, sort of the process of radiation. And then I think that would be a good introduction into talking about, you know, what we can do for breast cancer in particular in terms of avoiding complications to the heart long term. So what is a radiation oncologist? Well, in one sentence, basically, it's an oncologist that uses radiation to treat cancer. So what we do is we evaluate patients in a consult, see if they're appropriate candidates for radiation. And then if they are, then we go ahead and do what's called a simulation, where we set them up in a treatment position, usually with a CAT scanner. And then we design a plan. And then that plan gets generated over about, you know, a week or 10 days, depending on how complicated the case is. And then we supervise the radiation treatments and how many treatments people get, how they're delivered. We manage the side effects of the radiation during the treatment. And then we usually follow patients afterwards for long-term side effects, as well as to monitor, of course, for cancer recurrence. The training, usually it's a standard medical school, and then we usually do 5 years of residency training. And we are certified by the American Board of Radiology, but just to be confusing, of course, we're not radiologists. We're actually a section of the Board of Radiology. So with that said, we've been using radiation to treat cancer for over 100 years. The first use of it was actually in 1896 with X-rays in particular. It was actually used to palliate a chest wall mass in a patient that had a recurrence after a mastectomy. And so many patients with cancer will get radiation. About 2/3 of all cancer patients will get radiation at some point, whether it's initially for cure or some patients where it's more advanced and you need to do what's called palliation to help pain and things like that due to cancer. Radiation essentially consists of high energy beams, just like visible light is a beam, but X-rays you can't see because they have more energy to them. And they're focused on either a tumor or a region that is at risk for microscopic cancer cells. So in breast cancer would be, for example, the breast or the lymph nodes. And what happens is the X-rays damage the cancer cell DNA. And in doing so, the cancers aren't able to replicate, and eventually they die off over time. While this is great and it works really well in many cases, the problem is that there's issues with collateral damage to normal tissues that are near the target area. So in particular, the heart can be a problem sometimes, particularly with breast cancers. So there's a lot of physics involved, but I'll spare you all that for now. As far as the process is concerned, it usually takes about 1 to 3 weeks from the time I see a patient to the time the patient actually starts the treatment. You know, the steps are consultation, where we visit and just talking usually with patients. A lot of patients come in and think they're going to get treated that day, and usually have to kind of reassure them that we're just there to talk and kind of review the treatment. Next step, of course, is to plan it out or map it out, what we call a simulation on a CAT scanner. And then the planning process happens where we design the breast treatment. And so here in this little picture, you see a little cloud of green and red radiation dose over the left breast. So this is a patient that was getting planned. And then the treatment itself is delivered when the plan has been approved, and it's delivered via a linear accelerator, which uses an X-ray beam, as highlighted by this reddish beam that kind of comes over and clips the breast from the middle, and then also shoots another X-ray beam from the side to treat that left breast. We have probably one of the more advanced linear accelerators in the area. It's a variant TrueBeam, which was just installed in January and is probably the top machine to treat patients with in terms of radiation. It's been a great machine. So as far as the planning, it's really the most time-consuming process. A lot of calculations have to be made. Sometimes there's issues with organs in the area, such as the heart in particular, with breast cancers. So we really take a while to get things together and make sure it's safe before we start treating anybody. And it takes time to do. So sometimes, you know, patients may be waiting a week to 2 weeks if it's complicated. If it's not, it can be a couple of days. So there is a lot of work that goes on behind the scenes. For breast cancer treatment in general, usually most patients, the planning time, you know, is about 3 to 5 days for just a simple stage 1 breast. If lymph nodes need to be treated or patients are post-mastectomy, it can take a little bit longer. There's some more issues with that. So as far as its role in breast cancer, so radiation most commonly is used after surgery to eradicate microscopic cancer cells in the breast in order to reduce the risk of their cancer coming back. It's more commonly used after a lumpectomy, basically to sterilize the breast and reduce the risk of the cancer coming back. The cure rate with lumpectomy and radiation is actually equal to mastectomy in appropriately selected patients. There are some patients that may not have genetic risk factors for breast cancer, but still want a mastectomy, thinking that it might have a higher cure rate. It actually doesn't. It's essentially the same. And there's about 40 years of data supporting that. So most patients will undergo lumpectomy and radiation unless they have some other risk factors or are not good candidates for other reasons. Some patients undergoing mastectomy may still require radiation if the tumor is particularly large or if there are positive lymph nodes. And then the number of treatments for radiation for breast cancer, there's a wide range. It's anywhere from 1 to 6 weeks. I would say the majority of patients nowadays are candidates for a 3-week treatment course. 6 weeks, it's more if we need to treat lymph nodes, but the majority of patients we see tend to be early stage and typically get about 3 to 4 weeks of treatment. In terms of side effects, we divide the side effects of radiation into 2 categories, and this is specific to breast cancer. So the most common side effect is going to be some skin redness and peeling, kind of like a sunburn. They usually occur during radiation for, up to, usually they kick in about a week into the treatment. You get a little bit of redness, and then by the end they can then get a little bit red and sometimes can peel like a sunburn can peel. So that's the most bothersome side effect during the treatment for breast cancer. Fatigue is also kind of an issue, but many patients that I see and treat do their daily activities. I have many women that come in on their lunch break and go back to work and do it. So most patients can do pretty well with breast radiation without having to stop what they normally do. There are some long-term side effects to consider as well. These are things that can occur months to years later. They're not as common, but we review them with every patient at the time of a consult. So, there can always be some scar tissue that forms in the breast after radiation. It can get thicker. And some patients, it can shrink a little bit. But most patients do pretty well afterwards. Usually they're pretty happy with the way the breast looks cosmetically, if they're happy with the way the breast looks after surgery in most cases. But some patients, a few percent, can have some shrinkage. There can be some skin darkening or tanning of the skin. Can get a little bit of scar tissue in the lung, but not a lot, usually not enough to cause any breathing issues. And there's always a rare risk of the radiation causing cancer, but it's pretty low. It's less than 1% in adults, and it can take 20 to 30 years to show up. We worry about it more in kids. And then the other thing we always talk about with breast cancer, particularly if it's a left breast cancer, is there's a risk of increased heart disease, things like hardening of the arteries or heart attacks. And so this is sort of why. So historically, it's been considered a risk factor for heart disease, patients that get radiation near the heart. And it's mainly in patients that have left breast cancers. And so this picture here is a CT slice. And then this pink outline is the left breast. And this sort of purple outline would be the path of the radiation as it comes in to treat the left breast. And as you can see, this yellow structure here, this is the heart. And the radiation would pass right through this, what we call portion of the left ventricle, which is the strongest part of the heart, and the part of the heart that's responsible for pumping the blood throughout the body. So it can cause hardening of the arteries, which are located kind of in this middle area here. And so this has been an issue in patients treated, for years. And, we try to minimize the dose of the heart to avoid that long-term risk of heart disease. And this became an issue a couple of years ago. Back in 2013, there was a big study published in New England Journal, which looked at patients treated in Scandinavia, so Sweden, Denmark, who got radiation for breast cancer between 1958 and 2001. And they actually showed that there definitely was an increased risk of some heart issues in patients that got radiation versus patients that did not get radiation. And these charts below sort of show that the risk starts increasing about 5 years after treatment and can be seen up to 20 years later. And so down at the bottom left, you can see that there's 2 graphs. One is showing the risk of death from heart disease. And then the other one next to it in B is the risk of a coronary event like a heart attack. And so the solid lines represent patients that did not get radiation. And then the dashed lines are patients that did get radiation. The dotted lines are patients that got radiation and got a very high dose of radiation to the heart. And so there definitely is an increased risk of heart issues in the patients that got radiation, but it's most pronounced in patients that got a dose of what we call 10 gray. Gray is the unit of radiation we use to measure. Patients that got lower dose, such as 3 gray, they had a slightly higher risk, but it wasn't a statistically significant risk. Biggest issues are patients with pre-existing conditions and high heart doses. And then we also know that as the radiation dose of the heart increases, if you look at the graph on the right, as the higher the dose, the higher the risk of complications that can occur. So this was kind of scary, and people got very worried about it. There are some caveats about it, though. So the date range I gave you is 1958 to 2001, and the majority of the patients were treated with much older techniques, older technologies, which have significantly improved since many of those patients were treated. There have been other studies that have been done, particularly in patients treated in the 80s and 90s, where they did not actually see an increased risk of heart disease in patients getting radiation. So this study was a little controversial. And then as far as the increased risk, while it was higher, it wasn't dramatically so. So the average female at age 50 has a 1.9% chance of heart disease by age 80. If they got an excessive radiation dose of the heart, the risk does go up, but only goes up about 0.5% to 2.4%. So there was a relative increase of 22%, but the absolute increase, the likelihood they'll actually get heart disease, the increase to only about 0.5%. And a couple other things, they estimated the heart doses. They didn't have CAT scans available for most of these patients that actually properly estimate the dose of the heart, so they kind of guessed. But anyway, it was a thought-provoking study, and it does indicate that there is some association between radiation and heart disease. So what can we do about it? Well, one option is don't give radiation. And that's certainly an option for patients with early-stage breast cancer who are over the age of 70, who have tumors that we call hormone responsive, so they can be treated with a pill to suppress them. So that's a good option for older patients that might be at risk for cardiac issues to avoid radiation. There's still a small benefit to adding the radiation in terms of reducing the risk of it coming back, but it's a fair option for many patients over the age of 70 to simply avoid it and just take the hormonal therapy. Many patients, though, we can't avoid radiation, particularly if they're young. And those are the patients at biggest risk for issues with the heart after radiation because they're going to live a long time. So we could use alternative types of radiation, which I won't go into, but there's options like brachytherapy, which uses internal radiation in tumors after they've been removed. There's a form called intraoperative radiation, which is done in the operating room, but there's very limited availability of it right now. And then there's proton therapy, which is an excellent technique to spare the heart, but it's very expensive and availability is limited to major academic centers. So it's only appropriate in certain cases, and it's not very widely available. But there are some things we can do to avoid the heart. For example, we can shield the heart with blocking, what we call to prevent the radiation from passing through the heart. We can sometimes treat patients prone, in other words, on their stomach, and have the breast sort of hang down below the patient. That way it's pulled away from the heart. Or we can do something called deep-inspiratory breath hold, which patients take a deep breath in and hold it, and that displaces the heart away from the chest during the radiation treatment. And so that's what I'm going to talk to you guys about here. So it's a specialized technique for patients with left breast cancers, which by having them take a deep breath in, pushes the heart back away from the chest and allows the radiation to pass through the breast without passing through the heart. So I've been doing this since 2008, and then it's kind of been adopted in the community slowly over the next several years. We've had it here since 2017, and say the majority of our patients are candidates for it. And if they have a left-sided breast cancer, this is what we use. So there's sort of a little video here on the left, which will show you sort of the beam coming in on a standard patient. Here's the heart. And as you can see, it's passing right through a portion of the heart there, which can cause issues long-term. And so with breath hold, what happens, patient breathes in deeply, and then the heart is now pushed away from the radiation beam, which can come in and now treat the left breast without delivering a significant dose to the heart. And so I have a case just to really go through this. Is an actual patient I treated a couple of years ago. I was a young lady, 36, had a triple negative breast cancer in the left breast, and she had a lumpectomy, and she had a T2N0. And she got chemotherapy, which one of the drugs they gave was adriamycin, which can affect the heart long-term. So this would be an issue for this lady because she's young and got chemo that can affect the heart, and the radiation could also affect the heart. So this was a big issue with this patient. So she was seen for left breast radiation, and this was her initial treatment plan without breath hold. And here's the heart, and then you can see these lines here, which they indicate where the radiation is going, different doses, but a portion of them is cutting through the left portion of the heart here. And so we did a plan with breath hold, and you can see the difference here, where the heart is essentially completely outside of the radiation and the breast is getting the full dose. And so ultimately, this decreased the radiation dose by about 73%. As you can see here, we look at what's called the mean dose, which went from 342 centigrade down to about 90 centigrade. And so this level is fairly safe, much lower risk. So some of the take-home points from this, radiation dose can increase the risk of heart disease in patients. The risk was seen mostly in patients treated many, many years ago with older techniques. The increase does appear to be present, but it does appear to be small, even in patients treated with older techniques. So there is an increased risk, but it does not appear to be very high. But given the likelihood of curing most patients with stage 1 and 2 breast cancers, a lot of people may live long enough to potentially develop heart issues, and so this is an important thing to take into account. And there have been, technology advances that have made the radiation safer and more effective, as I listed below. And so as far as our center, one of the unique things is that we're one of the few places in Northwest Georgia that has a cutting edge technique like this. I don't think actually any other facilities near us, at least in Northwest Georgia, have this capability to do this. So this is something that we're very proud to offer here. Otherwise, just want to acknowledge my staff here, my partner, Dr. Ali, our physicists, radiation therapists, dosimetrists, and nursing and front desk staff. And thank you very much for the opportunity.
All right. I think I'm unmuted. So Dr. Gallinopoulos, I really appreciate all that information. Very proud of our radiation center and the staff there. They do an excellent job in taking care of our patients. We did have a chat question that Dr. Manahan did answer. I think it came through, and I'm not sure all the attendees were able to see it, but someone had asked if we have physical therapy available here for folks that undergo surgery and radiation therapy if they develop lymphedema. And the answer to that is yes. It is housed currently at the Bradley Wellness Center. Excellent team of physical therapists there that do a wonderful job with lymphedema. And just outstanding group there. Eventually, we have one additional floor at the PCI to build out. And once that has been completed, most likely the lymphedema will actually be housed here in the PCI, which is one of our future goals as well. So I appreciate that question. So with that said, we're going to go ahead and move on. Dr. Patel, if you're with us, can you share your screen?
All right, let me see if I can do that. Y'all see my slides?
Yes, I think so.
Okay, great. So first, thanks for having me. My name is Neil Patel. I am one of the partners in North Georgia Radiology. We've been providing radiology services for the community for more than 50 years, and we hope to be here for a lot longer. Unlike the rest of the panelists in this discussion, most of our patients don't ever get to see us. We're kind of the guys and gals behind the curtain. But also, unlike a lot of the panelists, probably everybody on here in some way has had undergone the care of a radiologist, whether they know it or not. So we read CTs, X-rays, ultrasounds, MRIs, nuclear medicine images, PET images. So if you've ever had any sort of imaging, a radiologist has probably looked at that. And so I know I've met some of you face to face. So thanks again for having me. And we'll get started. Today I'm going to talk about mammography, a hot topic in a lot of circles and something that we strive to do really well here at Hamilton. We've got some new advances that have come in the last couple of years and some more coming up. So Breast cancer screening is done with mammography. Most of y'all probably know that. For cancer, what we have found across all modalities is that if we are able to detect cancer early on in its course, the outcomes are usually better. Cure the cancer either with radiation therapies or oncologic therapies or surgical therapies like other today. And that usually leads to better outcomes. Saving lives is what we're trying to do. And so the best way to find cancers early is to undergo screening tests at appropriate timelines. Oftentimes screening tests, patients don't want to come in to get a screening test because they're usually asymptomatic. Most people don't go to the doctor unless they're having problems. But a screening test is an example, for example, mammography, is an example of why you might need to go to the doctor even when you're asymptomatic. So other screening tests that people are familiar with are things like colonoscopies, low-dose lung cancer screenings, other screening tests of those types. At Hamilton, we're fortunate to have state-of-the-art care. Dr. Gallinopoulos just shared a lot of the technology from radiation oncology. Dr. Manhan shared some of the new hair-sparing techniques that he's brought to the community. And we're offering some of those similar new and upcoming technologies through radiology. Most recently, we got a 3D tomosynthesis mammography unit, which I'll talk about later on in this presentation. So this is just a slide from the American Cancer Society helping, hopefully all of you see when you need to get your screening mammogram. There's some variability on recommendations, and I'll share my thoughts after when we get to this at the end of this slide. So this is for the average risk of breast cancer. Dr. Manahan talked about patients that are at increased risk of breast cancer, either based on family history or any genetic screening that has already taken place. We'll talk about that in a minute, but this slide is for the average risk. So women ages 40 to 44 should start having an annual mammogram. And so if you think about that, that's every year around the same time of the year if possible. And that is the recommendation from the American Cancer Society. I agree with that recommendation. And then we continue that from 45 to 54. So 40 to 44 actually have the option to start screening. 45 to 54 is when we should start screening. Some other societies recommend actually starting the screening at 40. I think that earlier screening is a good thing, especially if you have risk factors for cancer. So 45 to 44, I think everybody agrees. 45 to 54, everybody agrees that you should have screening mammograms every year. At age 55 is where things can kind of get tricky. The American Cancer Society recommends they can go to patients go to every other year, or they can continue yearly mammograms, and that screening should be continued as long as a woman is in good health and expect to live more than 10 years. I think at 55, women should continue to have annual mammograms. The American College of Radiology actually suggests that over 55 patients should continue to have screening mammograms and continue to have them at least until they're expected to live 10 more years. One thing you can do is discuss with your healthcare provider your annual wellness exam. For a lot of women, that's their OBGYN, possibly your PCP or any other primary doctor that you have. This is a very busy slide, so I'll try and make this not as confusing. If you look at the top, this is for high-risk women. So either patients that have had breast cancer before, or have family history of breast cancer in certain relatives, or have already had genetic testing and have been proven to be at high risk. So the big deal about high-risk breast cancers, patients with high risk of breast cancers, is that they may develop breast cancer earlier in their life. And so this brings the question of these patients may need to have yearly mammograms before the age of 40. This can be seen sometimes if you have a first-degree relative with breast cancer, or a second-degree relative on certain sides of the family with breast cancer. So if you are at high risk, you may need to be screened before the age of 40. And this screening could come in the form of mammogram and breast MRI, starting at an earlier age, depending on what sort of gene mutation you might have, or if you have other syndromes that increase your risk for breast cancer. We have a mammogram, we have multiple mammogram units. We actually have the new Pristina mammogram unit, which some of you may have already experienced. It allows you to control your own breast compression, which women really like. It's nice to have control of the feelings that you're going to feel. And so we've been using that, and we've had some good feedback on that. Like Dr. Turner stated at the beginning, we're in the process of getting a 3T MRI, and that's going to help with breast MRI, which we'll hopefully start doing soon as well. So why do you need a mammogram? We talked about it a little bit at the beginning. Cancer detected early has better outcomes. What we are looking for in a mammogram is changes in the breast tissue. When I talk to patients, I explain mammograms as every page you read tells a story. When you skip pages or you skip years in your mammogram, it's hard to make the story make sense. So what we're looking for is changes, and when you skip years in your mammogram, it's hard to detect these changes, harder to detect these changes than when you come every year. It's easier for us to put the story together. So we're looking for breast changes, calcifications, and masses. A screening mammogram, it's like I said earlier, is used to detect cancer in women who don't have any breast symptoms or problems. Typically, again, like I said, these are asymptomatic. So like I said before, 3D mammography is something that we just started doing a couple years ago. It's considered close to the standard, but again, we're fortunate to have it in a town like Dalton. Not a lot of smaller towns have it, and we've been using it ever since we got it. So the goal with 3D mammograms compared to 2D mammograms is to reduce the number of false positives. So false positives are patients that we believe have cancer, but end up not having cancer. And so what this really helps is, this helps in patients that have really dense breast. Breast density is affected by age and menopausal status as well as medication. For the most part, we don't have a lot of dense breast patients, but it's really helpful in these patients that do have dense breast. It's also helpful in patients that have increased risk, genetic factors, things like that. So this is just an example of how this helps us. So on the left, we have a 2D image. And there's an area right here that would be very difficult to identify as an area of cancer. It kind of blurs and blends in with everything else. But when we do a 3D image, which actually helps us take out some of the noise and take smaller slices through the breast, you can see how this area stands out, particularly in this view, much better. Now imagine if you were trying to find something that looked like this and all of this mess, it would be very difficult to identify. It's there, trust me, but it's much easier to see on the 3D view. So this technology allows us to find cancers much earlier, but it also allows us to make sure that the things that we don't think are cancer truly aren't cancer. Clinical and self-breast exams have been popular lately, so we'll just review these slides. Self-breast exam is done by women themselves. The clinical breast exam is also often done by the healthcare provider, their OBGYN or the nice thing about clinical breast exams is that they're free, at least. And they can be done every day or every week or however often you want. I tell patients that it's best. We love being your doctors, but you know your body very well also. And so if you can do clinical breast exams, I would recommend doing that. Oftentimes patients will pick up on an abnormality long before their physician will, just because we don't see you every day or every week or even every month. And then if you pick up on something, we'll make sure to let your provider or your doctor, your OBGYN or PCP know so that we can have that evaluated. While breast exams are great, clinical breast exams are great, they do not replace mammography. Women can feel abnormalities in their breasts, but oftentimes deeper, smaller cancers are not going to be picked up on a clinical breast exam. So this is not a replacement for your standard screening study. So just a few takeaways: know your risk. Like Dr. Manahan encouraged everybody, know about your family history, get genetic testing if you need to. Talk to your providers about who's had cancer in your family and what cancers you might be at risk for. We love taking care of everybody in the community. Schedule your mammogram with us. We provide mammograms services 5 days a week, and so we're here to help you guys.
He's answering that.
Back to you, Dr. Turner.
Yeah, thank you, Dr. Patel. You cut out just a little bit there at the end, but again, the number we had a question about, do we do annual mammography screening at the PCI, and the answer to that was definitely yes. And the number's there if you need to call and get an appointment. We'd love to take care of you here. I think I was just looking through the questions for Dr. Patel and potentially Dr. Manahan. I know he's answering some. There was a question, if you're at high risk, how much more frequent should you be screened more than once a year? I would open that up to the panelists, any of you to maybe answer that question. All of you can take a shot at it. Dr. Manahan, you want to?
Yep. So for high risk, which is considered greater than 20% lifetime risk in a calculated score, or if you have a genetic abnormality, you should have an MRI every year. ACR recommendations, MRI yearly. And then also you split that up. 6 months later, you'd get a mammogram, and then 6 months later, you get an MRI. So something is imaging your breast every 6 months. And so you split it between MRI and screening 3D mammography.
Okay. Dr. Patel, Dr. Galanopoulos, any additions to that?
No, I agree. That's what the ACR recommends. It's basically more frequent screening and higher technical screening with the MRI. So if you have an increased risk, you absolutely need to be screened on a different schedule than somebody who has a low risk or just even an average risk.
Okay.
Yeah, I would agree with that as well. And also make a note, there are some patients that have received radiation as children or teenagers, sometimes for lymphoma. So in females, we typically recommend early screening, usually starting around age 30, depending, usually with MRI at that point, just because of the density of the breasts.
And the last other thing is 10 years, we typically will go start screening 10 years before the earliest diagnosis of breast cancer. So age 40, breast cancer, start yearly screening at age 30. Just if you're getting into screening, but not necessarily high risk. So again, 10 years earlier, or everybody starting at age 40 annually forever until at least you're very elderly.
All right. Again, thank you, Dr. Patel, for that excellent overview of our screening and radiology options here. We will finish out our session on our webinar with Victoria Eidson, who is our registered dietitian at the People's Cancer Institute. She kind of splits time between the PCI as well as Bradley Wellness Center. And Victoria is going to talk to us about some preventative nutrition. So Victoria can share her screen.
All right, can you see my screen?
Yes, you see it? Yes, I think we're good.
All right. My name is Victoria, and I'm the registered dietitian at People's Cancer Institute and at the Bradley Wellness Center. Today, I'm just going to be talking about some nutrition and what you can do and what's in your control to prevent cancer, and specifically breast cancer. So when it comes to cancer and cancer prevention, just some things to get started. So 1/4 to 1/3 of all cancers could be prevented by choosing a healthy diet pattern and physical activity. Just some general cancer prevention tips include not smoking, avoiding other types of tobacco exposure, avoiding excess sun exposure. When it comes to breast cancer and breast cancer prevention, approximately 20% of postmenopausal breast cancer is actually attributed to being overweight or obese. This is because the fat tissue is the primary site of estrogen production. So we're just going to go through some different points, touch on some different subjects as to what you can do, again, to reduce your cancer risk. So first things, just starting off with body weight. It's important to be as lean as possible while still being within what's considered your normal range for body weight for your size. Avoiding weight gain and any increases in waist circumference. Intentional weight loss is actually associated with a decrease in cancer risk. And when talking about cancer treatment, weight gain during treatment or being overweight during then may actually increase the risk of cancer reoccurrence. The next point, just to talk about physical activity. It's important to be moderately physically active for at least 30 minutes every day. This can even include brisk walking, trying to limit sedentary behaviors such as sitting or watching TV. Not only does this exercise help with weight management, like we had just talked about, but the physical activity itself has its own cancer protective benefits, regardless of your body weight. The third point, sugar-sweetened beverages. It's important to try and limit your consumption of these drinks and to consume fast foods sparingly. There's a picture of these on the slide as to what would be considered a sugar-sweetened beverage. These are very energy-dense foods and drinks, and they can lead to that weight gain that we're trying to prevent. Another point is plant foods. So eating mostly plant foods or plants from that origin, choosing whole grains, nuts, beans, legumes, and fruits and vegetables. Trying to eat more whole foods. The more color, obviously, the better. And when I say whole, for example, eating a whole orange rather than drinking orange juice, or eating whole fruits and vegetables rather than drinking a vegetable juice. That's because these plant foods are very rich in phytochemicals, vitamins, and minerals, and as part of that whole food can help prevent against cancer. They also contain high fiber, which can also reduce breast cancer risk. So the goal is to aim for about 5 servings of fruits and vegetables per day, and this is about the equivalent of 2.5 cups. So talking about animal foods, it's important to try and limit your intake of red meat to preferably no more than 18 ounces per week, trying to decrease your processed meat intake to as little as possible. And these processed meats that I'm referring to include the hot dogs, ham, bacon, pepperoni, sausages, etc. There's actually convincing evidence that these types of meats can lead to colon cancer, just on that note. So when it comes to animal foods, poultry and fish are the most preferable animal foods, but every type of meat, can be included in a healthy diet if, in moderation. When it comes to alcohol, there is convincing evidence that alcoholic drinks are a cause of both pre- and postmenopausal breast cancer. So it is important to limit your consumption. And if consumed, try to limit it to no more than 2 drinks per day for men and 1 per day for women. And if you look on the screen at this image, it kind of shows you what actually is a serving size of a drink of these different types of alcoholic beverages. Another point is the sodium. So trying to limit your consumption of salt to less than 2,000 milligrams in one day, whether that's being added to your food or in the foods that you're already consuming. Ideally, we don't want more than 1,500 milligrams per day, as stated by the American Heart Association. If you can compare the nutrition facts labels on packaged foods and try and pick the lower sodium milligrams, that would be the heart healthiest choice. Trying to use herbs and spices instead of salt when cooking. For example, Mrs. Dash is a seasoning blend that has no salt in it. That's a great alternative to trying to make your foods taste good, but trying to limit the sodium intake. Just some other points when it comes to cancer, dietary supplements. So actually, dietary supplements are not recommended for cancer prevention. The goal is to meet your nutritional needs and vitamins and mineral intake through diet alone. And if you're following these lifestyle recommendations that we are just talking about, these supplements aren't really needed to reduce your cancer risk. There's no evidence suggesting that these supplements provide the same anti-cancer benefits as eating whole fruits and vegetables. In fact, some high-dose supplements, specifically vitamins A and E, can actually increase your cancer risk. So again, the more color and the more types of whole fruits and vegetables that you can eat, the better, aiming for that 2.5 cups of fruits and vegetables per day. And lastly, just breastfeeding. So research suggests that not only do we know that breastfeeding is very beneficial for babies, but it can actually reduce a mother's risk of both pre- and postmenopausal breast cancer. So for mothers, aim to breastfeed infants up to 6 months exclusively before introducing other liquids or solids. If you're looking for assistance, along the way to trying to live a healthier lifestyle, the American Institute of Cancer Research has some great resources out there. They have a bunch of healthy recipes as well. The best part actually is their new American Plate Challenge. So it's a free 12-week program that you can kind of hold yourself accountable to. They focus on a different topic each week. Their 2019 version is the one that's currently up, but you have free access to it and you can kind of go through one different thing each week, and that can kind of help you along your journey to becoming a little bit healthier. And also, on the next slide, whoops. They have a 30-day cancer prevention checklist, which you can print out and post, wherever, if that's something that'll help keep yourself accountable and trying to make healthier lifestyle choices. And the last thing, just some credible nutrition sources out there. I know there's a lot out there on the internet, especially. My Plate and Eat Right, they got a lot of articles, recipes, videos, bunch of visuals, great information for all different ages. So again, I'm a registered dietitian at the People's Cancer Institute and at the Bradley Wellness Center. If interested in meeting with me, I'd love to talk and schedule an appointment with you. But that is all from me. I hope that was helpful. And are there any questions?
Yeah, I'll do that. Go ahead and go to that last slide. Yeah. Okay.
Can I have a question? So if I was a patient and I wanted to meet with you, what do I do? Who do I call? Just call PCI, the Wellness Center? How do I get an appointment?
So I think you could just call PCI and ask for me. Same with the Wellness Center. They can put you in contact with me. Do you have any other, would there be a better way of going about that?
Yeah, I mean, I think if you call the PCI, we can get you in touch with them so that if there's questions or a meeting, we should be able to make that happen.
Okay.
Yeah, get them on schedule. Okay. And I think I'm looking, I don't see any additional questions specifically. There's one question I do want to address that came up, which I thought was a really good one, and it's sort of a general question and very applicable to our current societal issue of COVID. A question came up was, does COVID, a diagnosis of COVID, does it affect what treatment a person can have, or does it delay the therapy that you might have? And that's a really good question. Dr. Manahan and I, when COVID first started back, late February, March, we actually spent a lot of time with some of his other national breast surgeon colleagues doing some webinars and certain things, because this question was really looked at pretty heavily because if you're taking chemotherapy or you need chemotherapy, and your immune system, which is inherently going to take is going to be declined to some degree during chemotherapy, you can not only affect someone who has COVID, but you may also be putting someone at some point of an increased risk of getting COVID if exposed. A lot of emphasis went into the timing of therapies, not only surgery, but also for women that were ER positive or hormonally driven, of how to sequence that. So maybe taking an estrogen blocking pill before surgery and sort of delaying the surgery out. The availability early on of having personal protective equipment, the PPE that everyone was hearing about, also was kind of a driver in how we sequence things. Things have settled out a little bit, and we're probably a little more standard now than we were. And certainly we never want anyone to not have therapy or have it delayed, but there were some sequencing guidelines kind of put out there. Dr. Manahan, if you want to add anything to that?
I think the biggest opportunity also is the risk screening. We lost probably three good months of risk screening. So we want to get people in. I think we've got capacity here. A lot of places lost capacity to get people back in after COVID. So they do everything they can at PCI to really mitigate any risk for COVID and wipe down the machines and have staggered appointments. So I think there's still plenty of availability to get your screening mammography performed as well.
Okay. And so, again, I want to just personally thank everyone for attending. Hopefully this has been educational and helpful. I hope it's been informative, and I also want to thank our panelists, Dr. Manahan, Dr. Galanopoulos, Dr. Patel, and Victoria Edson for their participation and their expertise in their fields. And again, hopefully everyone gained a great deal of knowledge out of this. We do value your feedback. We had a few technical hiccups, but I think all in all, I want to thank Rachel as well for being here by my side and running the board and helping us with it. That there'll be a follow-up survey. It's going to pop up once we end the webinar. Take about a minute probably to fill it out. And if you'll do that for me, I would appreciate it. And again, if other questions come up, feel free to call the PCI. We'll find someone to answer your question and get back to you. So we're always here to help the community. So we appreciate it. And again, thanks for attending.